So I'll be talking about cyclodialysis cleft repair. So basically, by definition, is separation of the meridional ciliary muscle fiber from the scleral spur. And which one? This one. So there is an additional drainage pathway. So increasing the uscleral outflow, which leads to the ocular hypotony. So iatrogenic, basically post surgery or post trauma. That is two most common thing. Inadvertently during the cataract surgery now with clear corneal is literally zero, but during the if you are making scleral tunnel for the SICAs or the older technique, then the risk of cleft is high or trauma. So my majority of the patient is trauma. Some the beginning people when they are doing the trap, that time if you go too deep, then you can cut the ciliary body. So hypotony leads to effusion, cystal macular edema, optic disc edema, and retinal folds, shallow anterior chamber, all cataract are all the sequel of the cleft. This is basically related to the hypotony. The diagnosis is gonioscopy. If you know how to do gonioscopy, then you can diagnose the cleft. Patient has hypotony, pressures are unrecordably low, and the gonioscopy shows cleft. Of course, you have to rule out the retinal pathology. And confirmatory diagnosis of UVM, you can see this is the cleft. So the provides the detailed UVM if you have a facility of UBM, or if you know where the UBM is done properly. UBM gives a very clear idea, and you can get the whole longitudinal and the circumciliary extent, and you can get the how much clock hours of the cleft is there. So UBM is confirmatory as well as helps in making the surgical decision as and when you if you need it. This is so this is, you can see the gonioscopy, and this is the cleft. So treatment is medical management, laser treatment and surgical options. If the cleft is less than 1 clock hour, you can try topical atropine. Definitely myotic steroid should be avoided. Less than half clock hour, it works very well. The only thing that if you are given atropine, you have to be very sure. Explain the patient, because when the cleft closes suddenly, the IOP can shoot up to 50 and 60 or more also. So you explain the patient about that what happens to high IOP, or have a regular checkup. That is one of the limitation. Even post surgery, the same thing can happen, because when you close the cleft, the IOP can shoot up to 60 and 70. Laser treatment I have not done, but this is a described technique. Argon laser around the cleft I have not done, so I don't have any experience. If Ronnie or somebody else done, then we'll talk about later. So surgical option is external transconjunctival cryotherapy, pseudochoroidal diathermy, anterior buckling, and direct cycloplexy. I have only done direct cycloplexy in all my patients, and I'll be talking about that only. I have never done anything else. So general or local anesthesia depending upon the age of the patients. If the patient is young, of course, it's better to do under general. Inject high viscoelastic material in the anterior chamber, because you have to raise the IOP. Then you have to identify again on table with the help of the surgical gonio lens. Now we have much better surgical gonio lens available, hand free and all that, so we can exactly localize, confirm and mark the cleft outside, because that is the area we are going to open it. Take the traction suture, open it, and you can directly localize the cleft. So what we do usually, 4 millimeter posterior the limbus, partial thickness lamellar limbus base scleral flap. If you have cleft of let's say 3 clock hour, your incision should be at least 6 millimeter. At least 1 clock hour on either side more. Now I opened up, and this is the cleft I'm visualizing here. So 1 millimeter posterior scleral spur, at least 2 millimeter horizontal incision. Incision ideally should be at least 0.4. I would say 1 millimeter over the remaining sclera. Then from the scleral lip to cleft area, posterior cleft area, posterior scleral lip, close, and use 8O or 9O. If you use 10O suture, what will happen that the pressure will go up if you completely close the cleft. If you are lucky and you have missed little bit of cleft, then IOP will not spike. Otherwise, if you have taken 10O, when the pressure shoots up, your 10O suture will break very likely. So if you have 8O or 9O, that is the best suture to use if you are closing the cleft. So from anterior ciliary cleft, posterior lip, close it. Take multiple sutures. Close this outer scleral flap, conjunctival closure. So this is my post-op patients. You do gonioscopy and you can see the cleft is closed now. Now this is a small video. So this patient had traumatic cataract surgery, had a trauma, cataract surgery, and then patient was referred. So I don't know whether it was because of the trauma or because of the cataract surgery, but patient had a cleft. You have filled the visco. Now I'm using the lens to localize the cleft, and you can see the cleft has been localized. You mark outside. I'm seeing the other area. You can also see angle recession. This whole is angle recession, not a cleft. Now conjunctival peritomy. Nicely cauterize the 4 millimeter. Make the superficial flap. Then a nice making a superficial flap. Here in this patient I had an inadvertent entry here and I had to take the extra suture. You can see here I'm little bit more superficial. So I have closed that. That area. That was not needed. I should have avoided that. Then 2 millimeter from the surgical limbus. Here is the incision. I have already marked my cleft area. Make a full thickness incision there. And see, this is the cleft. So I am going to open it. It was 3 clock hour. I am going to make 4.5 to 5 clock hour of incision. See this area. This is the cleft. So then anterior scleral, ciliary body, posterior edge of ciliary body, the cleft area, posterior scleral lip, and suture it. Multiple sutures. And then close the flap, close the conjunctiva. That's the end of surgery. So I have done 15 cases. I have seen 15 cases, 3 post cataract surgery, 2 trap, 1 post PKP, and 9 cases of post trauma. 2 were small, less than 1 clover. I can avoid medical treatment, spontaneous closure. 13 cases I have done surgery. 1 case had a persistent hypotony, and I referred to my retina colleague for the anterior scleral band. Otherwise, all my patients, 2 patients had IOP more than 60. So ideally, I would say that if I got only 2 patients with more than 60, that means my majority of the cleft were not completely closed. They were little bit of maybe 5 less than 1/4 clock hour or were remained open, and that's why the patient didn't went into the hypertony phase. So it's in a way not a good surgical technique. Otherwise, majority of your patient will have more than 60 millimeter mercury if your cleft is completely closed. Thank you.
Thank you, Rajul. So we have about, thank you everyone for finishing on time. We have about 15 minutes for questions, and then we'll have the keynote speaker. So, so Rajul, I'll start with you. So this is a combined therapeutic and glaucoma surgery that you do with slightly leaky clefts, or does it just happen by chance?
No, so no, not by chance. Ideally, I should have closed. I think I must have missed a small cleft here or there. Otherwise, if the cleft is completely closed, then theoretically they should get IOP spikes because of two reasons. One is that the trabecular meshwork has not worked for a long time, so they are malfunctional, and there is a ciliary overreaction and they produce more aqueous. So IOP should spike. So if they didn't go in majority of the patient, then that means I must have left, or I use sometime not all 10-0, some 9-0, some 10-0. So maybe my 10-0 must have broken.
Okay. So are there any questions from the audience? You're welcome to ask anything to any of the speakers.
Sir.
Yes.
So I'll just ask you the same question. What would you do if the pressure spikes? I mean,
Medical management.
and is it usually transient?
Yeah, usually transient.
I was going to ask you, Ronnie, a question about the scleral flap. Now, I see you make a superficial flap, and then you do the sclerotomy under that.
Yes.
Is there any harm in doing you can do a sclerotomy and a sclerectomy without a flap? Is there any problem with that?
No, there's no problem with that. In fact, I mean, we have two slightly different approaches. My colleague whose video I showed you, she actually prefers to do it under a flap. I just do a triangular flap and I do a sclerectomy, leave it like that. One of the triangular flaps, I knock off the apex. So that's essentially an unguarded sclerotomy under the conjunctiva.
Sure.
But that's fairly safe, and normally nowadays with glue available, you get very good conjunctival closure also.
Thanks, because
Ronnie,
I've been doing that for 30 years.
Yeah.
I was a bit worried that maybe I was doing something wrong.
If you just remove the superior flap,
Yes.
partial sclerectomy, and then make us
Yeah, so that's what we're
That's what-
discussing. So
Most of the times you can just do the closure of the superficial flap. But I had one scenario where the patient had 16 millimeters, and the patient had an effusion and came to us the first time, and they opened it, came closed. So with the discussion with the retinal surgeon, we had to do almost 270 degrees of superficial scleral flap removed completely, throw it off, and then the inner side we have made the 2 flaps and then the sclerectomy in 4 quadrants. So still the patient had persistent choroidals, and it took some time. So very short eyes, and we have to be very, very careful. It depends on the scleral thickness. So those are very rare case scenarios, but most of the time this techniques would do.
the sclera itself is abnormal because the fibers the arrangement is all completely gone. So you really need to debulk it sometimes. Yes, Thomas.
I have had cases where I do full thickness and take the triangle off.
Yes.
Okay. I do one flapped and one total triangle. And I've had cases where 2-3 years down the line, I find an effusion, I go back and look at it. I can't find out where the sclerectomy is.
It just
sclera
closes
is just grown back as so it's virgin.
In fact, you
sclera.
don't even need to wait few years much earlier than that. So it's amazing how aggressive this little healing